Good evening, everyone. It's Sunday, September 12th, and I am Debbie Hilbasell, and tonight we are going to do case list reviews. I'm pretty sure all of you know how to participate, pretty straightforward, but there's a little orange arrow in the upper right-hand corner of your screen, which can open and close the panel if for any reason it was in your way. It looks like most of you, I see one or two is using the telephone, but most of you are using your computer mic and speaker, so there's really nothing that you need to do. But if for some reason you are using telephone, if you click on the button Use Telephone, you'll get a phone number, an access code, and a PIN in order to participate in the webinar tonight. And then, of course, if you want to volunteer, you just raise your hand and then I will call on you. I'll unmute you from my end, and then you'll just need to make sure that you're unmuted on your own end. One of the things I'm going to do right now, though, is I'm going to lower everybody's hand for a second, because what I'd like to do is we're starting to get really big groups. We've got right now over 22 participants, and you know we can usually only get to about 6 candidates per evening. So if anyone has already gone in September and has already been called on, let's let the other people who are on who wish to participate, who haven't been called on yet, let's let them raise their hand first. All right, so what I want to do now is let me go ahead and escape from here, close out PowerPoint, and pull up the case list. All right, so what I'm looking for are volunteers who have not gone yet this month. And then I'll open it up. I just want to make sure. We'll start with Augustina. Are you there, Augustina?
I'm here. Can you hear me? Yeah.
Yep, I can now. I can now. How are you?
I'm doing well. How are you?
Good. And are you a general OBGYN?
Yes, sir.
All right. And when do you test?
December.
In December. All right, good. All right, so let me find, and you've turned your case list in, right?
Addison, the name
Yep,
Addison.
here you are.
Mm-hmm.
There we go. All right, so do you have a particular case or a particular case list you would like me to ask you about?
On my GYN list, I have a couple of urogyne anterior posterior repair that I would like to see what questions I could be asked from that on
Okay.
the pelvic floor dysfunction part. And I have one with the acute urinary retention, yeah.
Okay, so patient 14 and 15.
Yes.
All right, so let's just take a look at patient 14. Go ahead and present this patient to me. Tell me what her symptoms were, what you offered her, etc.
Hi, so patient was a 54-year-old G5P5 who presented to my clinic with complaints of bulging feeling in her vagina. These symptoms have been there for about a year, but the bothersome did not occur till 6 months ago. She denies any frequency, urgency, or difficulty emptying her bladder. She also denies any urgencies with this bulge. She just feels it's worsening at the end of the day and gets really uncomfortable. And
Okay. No, go ahead.
And that was the initial reason why she came to see me in clinic.
All right, so when you evaluated her, tell me how did you evaluate her?
So I do it both in the supine and the upright position. I have patient lay down using the POP-Q. I measure the different components of the charts, which is the vaginal hiatus, the total vaginal length, and I have them Valsalva, and I'll measure both the A and the B, the anterior and the posterior aspects. I also have them go ahead and stand up and Valsalva and see how far the bulge comes out to whilst in the upright position.
Okay, so what stage of pelvic prolapse was she?
She was a stage 3 cystocele and a stage 2 rectocele.
All right, so what about her uterus?
She still had her uterus and she didn't have any apical descent. Her uterus and cervix did not have any significant prolapse.
So with the stage 3 cystocele, tell me, how did you evaluate her urinary tract prior to taking her to surgery?
So in most cases, we do, in my practice, we do have the urodynamics available, but since she did not complain on any urinary symptoms, I did not perform a urodynamics on her because she denies any retention or difficulty emptying her bladder.
Did you do a post-void residual on her?
No, I believe I did not do it. I didn't do that on her, no, not before
Did,
surgery.
did you evaluate her for incontinence?
I did. I have her Valsalva, and the way I check to see if she has any stress incontinence is a Valsalva or a cough test to see whether I have any urine during that time, any urgency.
Okay, and so what about, did you check for any evidence of occult stress incontinence? And do you know what I mean by that?
You mean when she coughs or sneezes, if she has any leakage or with a full bladder?
Oh, did you try reducing her
Yes, I did try.
prolapse? Did you try
Exactly.
reducing the stage 3 cystocele?
Yes, we did. I did try reducing it all the way. Yeah,
Okay,
uh-huh, to see whether she has any stress incontinence. Yes, we do that.
all right. And then tell me what type of lifestyle counseling you did on her.
So for lifestyle counseling, we talked about uh, Kegel exercises. At that time, she said she has attempted that at home with very little changes in her symptoms. We also talked about weight loss in terms of her obesity. She's obese. Her BMI was 36 at that time. So we talked about diet and exercise to try to improve her overall BMI. We also talk about avoid excessive weightlifting in terms of if she's going to exercise, not to engage in exercises that will increase her abdominal pressure. So basically, the exercises include walking, running, light weightlifting, swimming, and then, of course, we talked about her diet as well.
Did you offer her any conservative options besides Kegels and weight loss?
Yes, we did go over pessaries and different options for pessaries, but patient opted out of that because she said she's very sexually active and she will not be comfortable placing a pessary and removing it during sexual intercourse and placing it after. We did discuss pessaries, yes.
Oh, okay. All right. So you did an anterior and a posterior repair and then did a perineoplasty. Tell me about this acute urinary retention. What do you think was the cause of that?
So after surgery, patient was unable to void. We did scan her bladder and found 700 cc of urine in her bladder. At that time, she felt very uncomfortable, so we placed the Foley bag with a leg bag and educated her on how to empty it. I believe um, her acute retention was due to pain and edema around the urethra during her repair. And then after 24 hours, she returned to clinic. We did a post-void trial at that time, and she was able to completely void her, completely empty her bladder.
Okay, so when somebody does have a uterus in place but is complaining of symptomatic prolapse, when would you consider doing a
So I'm going to repeat your question. You said if the patient has her uterus in place and has an apical
Correct.
prolapse.
No, well, that's what you're answering my question. I said, if somebody has a uterus in place and has symptomatic prolapse, I didn't say what it was. That
Okay.
was, yeah. So you were heading down that path. The question is, when would you also recommend removal of the cervix and the uterus?
When they have a significant apical descent, I will counsel them about removal of the uterus and the cervix with the hope of um, providing a uterosacral ligament suspension to support the apex.
Okay. No, I think I don't know that there's a whole lot more that they can ask. There's a good practice bulletin that discusses pelvic organ prolapse. The key point of it is, and it was just published in the last couple of years, it's a ACOG practice bulletin. And the key point is about 40% of women who've had a vaginal delivery are going to have some degree of pelvic organ prolapse. The problem is a lot of them are asymptomatic. It's not a problem.
Mhm.
That much of it is asymptomatic. And so what we're really addressing with our patients is symptomatic pelvic prolapse. And you should be able to discuss, um, if you use Baden Walker, you should be able to grade it. If you use PopQ, you should be able to go through the staging. You should
Okay.
also then be able to talk about how you evaluate someone who comes in with prolapse, how you stage it, how you're going to evaluate, especially for occult stress incontinence. We see that primarily with procedentia, but you could see that with any significant prolapse, that once you've reduced the prolapse, now all of a sudden they develop stress incontinence. And of course, the big question is, at what point in time is the prolapse enough, even if you don't document SUI, that it's reasonable to almost do, quote, a prophylactic TVT? And
Mhm.
that's something that the urogynes, there's studies that can go either way with that.
Mhm.
The lifestyle changes, you're absolutely right. For obesity is going to make prolapse worse, as well as it's going to make incontinence worse. Doing Kegel exercises will help with just overall pelvic strength. It definitely helps with incontinence. It may help with prolapse, you know what I mean? But the
Mhm.
biggest thing would be to talk to her about a pessary versus surgical management, and you did that. So the only way that I would be a little more forthcoming if this was a patient who presented with symptomatic pelvic organ prolapse and obesity. I evaluated her. She had a I evaluated her using PopQ. She had a stage 3 cystocele, a stage 2 rectocele. I counseled her about conservative as well as surgical management. And then you could go back and say, with regards to conservative management, we discussed, all the things we did, including a pessary. The patient declined that, and this was the surgery that I did. And then if you want to talk about the acute urinary retention, I agree. It may be due to some of the narcotics which can cause urinary retention, as well as just trauma to the urethra from the surgery that was done.
Okay.
So good. All right. Thanks.
Thank you.
All right. Let me see then. Who are we gonna go next? All right. Amanda, have you really not gone this month? I thought I called on you before.
Hey, am I muted? Hi, I
Hey.
don't know if this counts. I went for one of the structure cases, but I haven't gone for my.
Oh, okay,
I
perfect.
wasn't
Then
sure if
let's
it
do
counted.
it. All right.
Okay.
Nope, let's do it then. Because I was like, I thought I called on you, young lady, but now I know. So let's find you. Here we go. Do you have a particular case or case list?
No. I guess since we just did a GYN, either an office practice or an OB.
All right, let's jump at office. It's sitting
Okay.
right here. Okay. Let me see where I would like to go. I know the office is such an odd one, isn't it?
It could be anything.
It could be anything. All right, let's look at patient 18, just because this is just an odd one. So you had a 79-year-old who came in with chronic pelvic pain, frequency, leakage, constipation, and then to make it even more difficult, she did have dementia, so it was difficult to get a really good history on her. So with regards to the chronic pelvic pain, how did you even know she had chronic pelvic pain?
She was referred to me by another provider for complaints of chronic pelvic pain. When I did a chart review, there were multiple visits in which she had endorsed it, and when I did my history, she was able to give me some history. Obviously, it was somewhat limited, but she did report some degree of pain.
Okay, so how did you evaluate it? Let's start first with her frequency and leakage, urinary leakage. So what was your differential diagnosis for that?
So for that, obviously, the history was a little bit limited, but my differential for that included a urinary tract infection, especially given the fact that she was complaining of chronic pain. It could have just been stress urinary incontinence or urge urinary incontinence or even mixed. The patient was older, and I don't, to be honest, don't remember off the top of my head if she had diabetes, but there could have been some, if she had had a long-standing chronic history of diabetes with underlying neuropathy, there could have even potentially been an overflow incontinence type of picture. It could have also been the patient also could have been, I guess you don't want to say this, but like as misinterpreting her symptoms or not remembering to go to the bathroom and then sort of leaking because she had it, or actually I guess it could be, I guess that would also be overflow incontinence, that she just didn't really know to go to the bathroom at that time, and she could have been having leakage because of that reason.
Okay, so when she comes in and has this chronic pelvic pain, tell me what you were tell me how your exam helped you.
So with my exam for any patient, I look at the patient's vital signs. Then I do a overall assessment of the patient. Are they well appearing? Do they appear to be in acute distress? And then for my physical exam, I do a general cardiopulmonary exam, but I pay more attention to my focused exam on the abdomen and the pelvis. So for her, when I evaluated her abdomen, I looked for any signs of abdominal tenderness, rebound, guarding, any potential palpable masses. When I did her pelvic exam, I looked for any visible abnormalities, any concerning findings with her external internal genitals, as well as her urethra and anus. And then when I did my bimanual exam, I assessed for any bimanual or cervical motion tenderness, like nexal tenderness, fullness, any tenderness posteriorly or anteriorly that could suggest a potentially different etiology, such as a bladder or like rectal sort of pain. And then also any sort of, I would also look for any sort of abnormal discharge, bleeding, any lesions, etc.
Okay, so how did you make the diagnosis of constipation?
The patient also was reporting difficulty with having regular bowel movements. From what I remember, this patient also was morbidly obese, so her exam was limited. But given her complaints of constipation, I empirically treated her with a stool softener. And given
Okay.
she did report improvement in symptoms after that, that's how I made the diagnosis.
Okay, and so then with regards to this chronic pelvic pain, and especially with the limited exam you were able to do, you got an ultrasound that was normal, you did your urine culture, showed E. coli, and then you addressed her constipation. So anyway, you put her on nitrofurotoin. So when you first got her urinalysis, while you're waiting for the culture to come back, what are you going to empirically just start the patient on while you're waiting for the culture to come back?
You could empirically treat a non-pregnant patient with nitrofurotoin or fosfomycin, I believe.
Yep. Or what else? There's one other one.
Um, I know in the past,
Nitrofurantoin, fosfomycin, or
I know in the past we did fluoroquinolones, but given increasing resistance and potential side effects, we sort of shied away from those.
correct.
Can't think of another one that we go to right off the top of my head.
Bactrim.
Bactrim, yes. Blank,
Yeah.
just blank on
So,
that.
yeah, no, that's the only reason why I just wanted to bring it up. You're 100% right, and I'm glad you brought that up to everybody else. In the olden days, you're right. We used to throw Cipro at everybody. You do not give fluoroquinolones unless you have absolutely no other choice because of the resistance and the side effects that can occur with the fluoroquinolone. So the three first-line drugs for UTIs are fosfomycin, nitrofurantoin, and trimethoprim sulfamethoxazole, which is way easier to just say Bactrim. Okay, so anyway, so you're going to treat this lady. Obviously, the culture came back consistent with that. What are you going to do if this patient keeps getting recurrent UTIs?
First, I would evaluate for any sort of lifestyle factors that we could address. Does in sort of hygiene? Does the patient have poor hygienic practices? Does she have any medical and then I would move on to any sort of medical factors that could be contributing to this. So, you know, poorly controlled diabetes, for example, or any other condition that could be causing her to have this issue. And then if we're not able to sort of address any contributing factors, then you could consider suppressive treatment.
Okay, anything else that you could do besides suppressive treatment or in addition to?
I have heard of some people suggesting the use of probiotics, but I don't know that it has been well studied in this situation.
Okay. Let me see what else I could add to this. I think that's probably, I'm going to stop there. I think you did a really nice job. You evaluate that when I asked you about the physical exam, you went through what things you're going to be looking for. You know, you're looking for abdominal wall pain. You're checking to see if you can reproduce the pain with pelvic floor dysfunction. Is it the bladder tender? Is it cervical motion tenderness? Whatever, you kind of work through all of that. With regard to chronic pelvic pain, constipation absolutely can be part of it. And then we add in our old patients then who are probably on multiple medications, which tons of medications can be constipating. Then you've got someone who's demented, so they're probably not drinking enough fluids, etc. And if they're obese, then she's probably not, you know, ambulating much, etc. So all of those things tie in. That was good that you evaluated the constipation. Then with regards to the urgency, the frequency, and the leakage, you're right. Does she have overactive bladder? Does she have stress incontinence? Does she have overflow incontinence? Is it mixed? In this case, I even think about functional incontinence, and I think that's where you were trying to go with. They just kind of forget to go to the bathroom, or
Yeah,
when
I
they
couldn't think
have,
of the
or
term. I
right,
was like, I've
or
heard something about
right,
this.
when they have the urge to go. Sometimes this can happen in patients who have limited mobility. They'll get the urge that's appropriate, but because of limited mobility, it just takes them too long, you know, to get out of their chair and try to actually hobble over to the bathroom, that they would actually start to leak themselves. All right, so that was good with that. You did the urine culture. Even if somebody has overactive bladder and you're treating it for it and all of a sudden it gets worse, you always have to rule out a UTI, because in the older patients, they oftentimes don't have associated dysuria. It's really more urgency, frequency, leakage. So you're absolutely right. You're going to always do a culture. So what I was trying to get at with what else you could do is vaginal estrogen. We do
Oh,
know
yes.
that postmenopausal women do have more UTIs. Number one, the tissue becomes thinner, the bacterial flora in the vagina changes, we get loss of the lactobacilli, and the pH becomes alkaline, and on and on. And so we can see for patients with recurrent UTIs, a trial of vaginal estrogen can also be very helpful. And you knew the 3 first-line antibiotics and why you shouldn't use Cipro. So perfect. Any questions?
No, I think this patient was surprisingly tough given evaluating her. I didn't really have much to work with, but thank you for helping me to break it down.
All right, thanks, Amanda. Alicia, will go to you next.
Okay.
Are you there? How are you?
Yes, I'm here. I'm good. How are you?
And good. And there we go. And are you a general OBGYN?
Yes, I am.
Okay, good. And when's your test?
In December.
In December. Okay, good. So do you have a particular case that you want to go over that you're concerned about, or do you want me just throw something at you?
Please just choose one.
Okay, let's go to the OB case list just because we'll try to keep rotating it and gotta keep it exciting. Where do you practice?
In Indiana.
Okay. All right, let me just see here. I want to just come up with something. Some of the ones that are somewhat interesting, but then when they're limited prenatal care, it kind of limits what I can ask. Let's look at patient 38. All right, so you had this 34-year-old who had growth restriction, borderline low AFI, and she was breech. So let's start with first things first. How did you make that diagnosis of growth restriction?
So diagnosis of growth restriction would occur when on ultrasound you have a estimated fetal weight of less than the 10th percentile or an abdominal circumference of less than the 10th percentile.
And tell me, when you do you do routine estimated fetal weights at different time through the pregnancy? If yes, tell me when.
So not routine, just based on the examination during the office visit. So if fundal heights begin to lag or the increase in fundal heights is tending to slow down, then that would be an indication to order an ultrasound to assess for fetal growth.
Okay, and so then once you've done that, you've made that diagnosis, tell me what sort of surveillance do you recall in this person, Alicia, when you actually, what gestational age you made that diagnosis?
I do not, unfortunately, but
Okay.
usually when I make the diagnosis is when I would initiate surveillance. And so the surveillance would include NSTs, and NSTs would occur twice weekly. Also growth ultrasounds once every few weeks, every 3 weeks, and then weekly ultrasounds for AFI and Dopplers.
Okay, so how with the AFI and the Dopplers, how are those going to help you with your assessment of fetal well-being, and how will they help you with regards to when you would want to deliver the patient?
So AFI and Dopplers are important to inform when the frequency of surveillance should be adjusted. So for example, if Dopplers became elevated, or if end diastolic flow became absent, that would be an indication to bring the patient into the hospital for closer surveillance. And the Dopplers could increase in frequency and occur twice weekly instead of just once weekly. And then if ever the end diastolic flow became reversed, that would be an indication to deliver.
All right, so what are some of different etiologies of growth restriction? So once you make the diagnosis, what do you need to be thinking about for different causes?
So growth restriction can be caused by a number of different causes, which could include like constitutionally, well, it would be important to make the distinction between growth restriction and constitutionally small fetus, because some babies just are going to be innately smaller than others. But growth restriction that is not just related to constitutionally small growing babies would potentially be caused by utero-placental insufficiency that might be caused by hypertension or diabetes, or sometimes you can get infectious causes of growth restriction. There can be causes like smoking, environmental causes. And those are the ones that are coming to mind right now.
Okay. All right. So anyway, so if this patient was obviously you were following her up with BPPs and stuff, so you knew what position she was. So she was breech with growth restriction and a borderline-ish AFI. So would you have even counseled her or discussed with her the possibility of a ECV? Why or why not?
So she, with the AFI being lower, that would make her less of a candidate for ECV, but it does not exclude her from the potential for an ECV. She would just need to be counseled regarding the likelihood of success with that finding. So it does not exclude her.
What else would make her less likely to be successful?
Fetal tolerance to the procedure, given that baby is growth restricted, there's a higher likelihood of fetal intolerance to the procedure.
What about looking at her parity?
So yes, multiparous patients are more likely to have a successful external cephalic version in comparison to no lips.
Okay. All right. So then anyway, so yeah, so even if you did counsel her about ECV, you absolutely would talk to her, the likelihood of success is lower. If she was one of those people that was adamant she wanted to do anything she could have to have a vaginal delivery, you're like, the baby may not be able to tolerate it, the fluid is less, and this is your first baby, all those things. And then if she was obese and other things like that would make it even other things that would help to go against it. So anyway, so you went through the different etiologies, the antenatal testing, her malpresentation, and so the decision then to do her section at 38 and 3 was based off of what? What made you do it at that gestational age?
So uncomplicated fetal growth restriction, should be delivered during the 38th week of gestation from, yes. So yes, uncomplicated growth restriction should be delivered during the 38th week of gestation. So she didn't have any other factors that made her need earlier delivery,
But her
such as
fluid,
like
what else? But her
actual
fluid
diagnosis
was
of
starting,
oligohydramnios.
right, her fluid was starting to get low. Why do we look at the amount of amniotic fluid? Why is that an important symptom or signal to us when we're watching a baby with growth restriction? What is, if somebody has low fluid or oligohydramnios, why does that happen with growth restriction?
So the fluid level is maintained by blood flow to the baby, and the baby has, so renal perfusion within the baby would allow for the fluid level to be maintained as the baby continues to make urine and repletes the amniotic fluid volume. So if we get a reduction in the amniotic fluid level, then that's letting us know that baby's not being perfused quite as well as a baby
Perfect.
who has
That's
a normal
exactly
fluid
right.
level.
Yeah, because the fluid, the amniotic fluid is coming from the fetal kidneys. And so if we're starting to see oligohydramnios or borderline fluids, that basically we can assume, unless she's ruptured and been leaking and we didn't know about it, that there's hypoperfusion to the fetal kidneys. And it's basically a surrogate marker for hypoperfusion of the placenta and hypoperfusion to the fetus. Very good. All right. So good. So you went over what's going to make you suspicious for restriction, what the testing you're going to do, why this patient wouldn't have been a great candidate for ECV, why you did her at when you did her, when you in her what I call her uncomplicated growth restriction, I guess uncomplicated-ish. I mean, she was starting to head toward decreased fluid, so I would have gotten her delivered also. The only thing I would suggest is when, with regards to when I went over the causes, you did a really nice job on the causes of fetal growth restriction, but sometimes when there's multiple things that you can pick, like there's all these different causes, sometimes it's nicer to almost like outline what you're thinking and then go back and fill it in. And what I mean by that is, if they said to you, so what do you think about with regards to growth restriction? I want you to say, I think about maternal causes, fetal causes, and placental causes. And that organizes your thoughts a little bit. And then you can go back, say, and then go, now with regards to maternal causes, and then what would be some maternal causes you could do? I'm going to make you do this again. So maternal causes of growth restriction, what would you come up with?
Is that including environmental, like smoking,
Yeah, absolutely.
hypertension, diabetes,
Yep.
and
Yeah, so that you would be like, you're thinking about any basically chronic maternal illness, but mostly hypertension, chronic hypertension. You're thinking about pre-gestational diabetes, but if they've got lupus or renal disease, or, think about any chronic disease. All right, then other things we know, like poor maternal weight gain or poor prematernal weight, but basically the other big one is substance abuse. So again, if we've got patients who are smokers, if they're methamphetamines, cocaine, those would be the maternal. So if we looked at fetal causes, what would be the fetal causes?
fetal causes, genetic abnormalities. Is this going to include torch infections?
Yep. That's pretty much it. It's the aneuploidies, the congenital anomalies, and the infections. That's pretty much what I can think of for fetal causes. You know, maybe I guess we could say multiple gestation. You know, that's going to increase the risk too. All right, placental causes. Although we know that most growth restriction comes down to uteroplacental insufficiency, there are other issues with the placental unit that can also cause it. Can you think of
Like
some other
circumvallate.
causes? Yep. What else? So circumvallate placenta.
Mm, I'm sure it's going to be obvious. Certainly, like if there was a chronic abruption,
Other things I would think about would be like velamentous cord insertion, if there was a two-vessel cord, like you said, circumvallate placenta, chronic abruption. But it's just kind of a way to be able to organize the thoughts a little bit. Just like if I said to you something about, so tell me, what are the risks of pregestational diabetes in pregnancy? What I would love you to say is, I think of it in terms of maternal risks and fetal risks. And then you could go through and go back to the maternal risk, you know, worsening diabetic retinopathy, you know, worsening of end organ damage, blah, 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 blah. And then you could go over with the ones that are unique to the fetus. Now, sometimes I'm like, okay, so what is a abruption? Is that a maternal or a fetal complication? I mean, it doesn't always fit that neatly into a package, but do you see what I'm saying? It can just help you to organize a little bit when you're nervous and there's a lot of differentials.
Got
Okay.
it. All right.
All
Thank
right,
you so
great.
much.
Thank you. All right, so it looks like I'm going to go ahead and lower the hands of the people who we've already called on. So now, how about anybody who else would like to go? So at least I've covered the people who haven't had an opportunity in September. So anybody else who would like to volunteer, please raise your hand. All right, let's go here. Ashley. Hey, Ashley, I think you're muted on your end. There you go.
Hi, how are you?
Good. Good. Let's see here. Let me pull you up. All right, so do you have a particular case or case list?
I do not, and I cannot even remember which case we did the last time we were together. So we can just go with, we just did OB, so maybe officer or GYN.
Let's do another GYN and see what we can come up with here. All right, let's just look at patient number 1 here. So you had this 43-year-old G5P5 presented with abdominal pain. So did she actually just did she come to the ER or just present to your office with pain?
She actually presented in an outside hospital and was transferred into our regional center for the abdominal pain after the imaging had shown a pelvic mass. This was a case in residency, and we were at a higher level of care than the originating facility.
All right, so go ahead and tell me then, did they do, well, just tell me how she was transferred to you. Tell me how she was evaluated, what your differential diagnosis was, why you did tumor markers, et cetera. Go ahead and just explain it to me.
Yes, so she had been presenting with several days of abdominal pain, was found to have this large mass in her abdomen. It was of a simple nature, but the originating physician had felt that, like I said, that they needed a higher level of care. Obviously on the diagnosis, the differential, I'm thinking of, just a simple simple ovarian cyst, a paratubal cyst, it's very large, but maybe a serous or mucinous cystadenoma. We always, with pelvic masses, have malignancy in the back of our mind. I suppose that this may be, very much less likely, this may be a pelvic mass or a mass that actually doesn't have to do anything with the gynecologic organs, but I would find that quite rare. At this time in particular, it was interesting because the transferring physician had intended on having the GYN-onc take the case, but the GYN-onc was unavailable. So there was another more seasoned generalist who accepted the transfer. And out of abundance of caution, despite the simple nature of the images, which were reviewed personally and by the attending, they had decided to take tumor markers just to make sure that we had the most information possible before going into the case.
Okay, so because this pain happened over a couple of days, were you thinking torsion when you went in, or were you just thinking this mass is just big and it's pushing on things and she's uncomfortable?
It's funny because with the size of it being so large, I think a lot of us would say, hey, this probably isn't going to torse because it's so big. Right. But with her being in pain, that's the thing. Did it torse? Is her pain because of something else? And she just happens to have this incidental 19 centimeter pelvic mass? We don't really know.
Okay.
It was a wait and find out kind of thing.
Oh, I'm sure. So anyway, so tell me, when you did the laparotomy, knowing you've got this mass that most likely is benign, but you don't know for sure what's going on, what type of an abdominal incision did you do?
So we made a midline vertical incision, especially because we weren't sure if we were going to need, general surgery or anyone else, based on our findings. So we did make a midline vertical incision for her.
Okay, and what did you see when you went in?
We saw this very, very large, simple pelvic mass that was attached to the adnexa, or was consuming the adnexa, I think is a better phrase.
And was it necrotic looking? Was it purple? I mean, you said something about it was torsed.
It was torsed, but what's interesting is it didn't, compared to other torsions I've seen with smaller, ovarian masses or just like regular sized ovaries, it did not appear so necrotic. It did not. Okay. It wasn't falling apart, thankfully.
Okay, so you're saying, but it was dusky in color, or am I putting words in your mouth?
It was dusky in color because it had been twisted several times. Okay. But it was, all right. Yeah.
All right. If this patient had been a 19-year-old G0, P0, would you have done exactly the same surgery?
I think that there would have been a much larger concern for ovarian conservation if possible, just because of her, very young age and nulliparity. However, this patient had been extensively counseled and was very certain that she was done with childbearing, as she had 5 children. And in making the discussion of potential risks, she was much more preoccupied with the idea of getting the mass taken out in one piece and not spilling any, with a potential risk of, if that was the very small chance that if this was malignant, that there would be spreading.
Okay, so then when you go in, it looked benign even on gross examination, correct?
Yeah, so yes, but you never, like, once it's so large, you never know until you open it, right?
Okay, so what do you mean by intraoperative pathology consultation? So did you send it for frozen, or?
We didn't. I do not believe we sent it for frozen, and I do need to check this, but I do know that we had pathology come in to do a gross exam, and they were like, this looks totally fine to me.
Okay. Oh, okay, good. So they actually came physically into the OR, took a look at the specimen after you had removed it?
Yes.
Okay, all right, got you. All right, so then it came back just a benign serous cystadenophybroma, but your instrument count was off. All right, so it was not a sponge count, it was an actual instrument missing?
That is correct. It was like a hemostat or something.
Okay. So tell me when they told you that you're short a hemostat, tell me how you proceeded to evaluate that.
Yes. So when the scrub tech had noted that the instrument count was incorrect, we stopped our procedure as the patient was in a stable condition, and everyone started to look for the instrument. So myself being scrubbed in and in front of the patient, we had, and actually I think, as a side note, the instrument that was missing was not even one that we had used or would have used in the surgery. But regardless, we're still looking for it. So we're looking in the abdomen manually. We're looking in the pockets of our drape. We had someone looking under our drape, on the floor, in the garbage, everything, looking to try to identify, find this missed instrument. At the same time, we had called radiology to have them come over to do a flat plate, because we know that was going to take a little bit of time to get them over, just in case we weren't able to find it by the time that they had arrived. The scrub tech had actually said that had wondered if maybe that instrument was never actually present in the room, and that it had just not been included in that particular tray. But regardless, we kept looking until the flat plate arrived and the patient received a flat plate. I got to look at the preliminary, but we waited for radiology to give us a final read before we closed.
All right, so when you do the flat plate, tell me what's important to ensure thoroughness of that flat plate.
What is important to ensure thoroughness of the flat plate?
Right. What I mean is, like, what are you X-raying? I guess let me put it that way.
So we are X-raying the abdomen, but also you have to take into account that there are multiple layers on the abdomen. So you have to know what metal, if you're looking for a metal thing, is laying on top of the abdomen, on the drape, or next to the drape, or like in the drape, or something like that, so that you can correlate it clinically, what you see. So if you had an instrument sitting on top of the patient's open abdomen, then you would have to remember that and tell the radiologist that, so that you don't confuse, or vice versa, so that you don't confuse something that is in the abdomen with something that's actually on top of the abdomen.
Okay, and maybe I'm just asking the question poorly, Ashley, but what my point is that when we are taking a X-ray of, quote, the abdomen, we need to make sure it's the entire abdomen, that they're getting, you can see both hip bones, you know what I'm saying? And you can
so
see
it's kind of abdomen pelvis is what you're saying.
Correct. That we're getting the pelvis all the way up to the lungs, because especially with sponges and stuff, they can get caught in the gutter and get pulled up and be back up behind the liver, even though you've been operating in the pelvis type thing. So just to make sure that you've got, you can see both hip bones and you can see both where the lungs are, so that you can ensure that no part of the abdominal cavity was not X-rayed or was not included in the X-ray. That was, I guess, what I was trying to say. Yeah, that's what makes me think that the initial count was something was goofed up. But that's right. You've got to, no matter what. Now, what did you tell the patient?
So I did not actually speak with this patient, but in general, if I had been the one who had spoken with the patient and family, I would have told them exactly what had happened. That there was an instrument count that was incorrect. We thankfully have steps in place that make it that everyone follows should we get into this kind of situation. We followed those. We did not find anything. We think that it was because of, as whatever I had mentioned before. At the same time, if you are experiencing fever, pain that is not being controlled by your medications, discharge from your incision, anything like that, I absolutely want you to call me, and I want you to come in to be seen as soon as possible to make sure that we're addressing your concerns.
And that's where it can get kind of tough, because if it doesn't matter if it's a sponge or if it's an instrument, but if you do an x-ray and nothing shows up, and you truly are doing the entire abdomen and you've got all your markers, it can't be in there. Do you know what I mean? It would
Right.
show up on the x-ray. Same thing with the sponges. So it is absolutely reasonable to talk to the patient after, tell them, hey, our sponge count was incorrect or our instrument count was incorrect. But the bottom line is, although we never found it, you've been x-rayed. It would show up on an x-ray. Having said that, just to be on the safe side, of course, anybody, we're going to tell them if they get fever or whatever afterwards to come back and see us. But I think it's good form to at least let them know that there were extra steps taken in order to ensure there wasn't either a sponge or instrument left in their abdominal cavity. So let's just talk about this, because I don't really have time to call in another person yet. So let's just do a little bit more education about adnexal masses. You had made a comment that you, because this was a simple cyst, somebody else who you felt was being very conservative actually did tumor markers. Well, tell me, when do you think tumor markers would be appropriate in evaluation of an adnexal mass?
So if you had any concerning findings on imaging, so nodularity, excrescences, findings of a complex cyst, obviously in a postmenopausal patient, we get the CA-125 quite frequently, quite liberally. Any other findings in the pelvis, usually these patients get a CT, so if there was any concern of, like a peritoneal signs or anything like that, I think those are typically, or clinically, if the patient, ascites would certainly be something where you would be suspicious for cancer. I believe that size is one of the potential reasons for getting tumor markers as well.
Yeah, there's a really good practice bulletin from a couple of years ago. It's just a really nice review. It's on, I think it's the diagnosis and the management of adnexal masses. I think that would be a high yield practice bulletin for everybody just to review. And it goes over, the differential diagnosis and the management of adnexal masses in our postmenopausal women, in our pregnant women, in our reproductive age women, and even in our premenarchal girls. So it really breaks it down into the different age categories, because that could certainly be a question on not only your GYN case list, but the office case list. How would you manage a adnexal mass? And it talks about which ones you can follow, torsion precautions, which complex masses you can follow conservatively, like endometriomas and mature cystic teratomas. If they're small and asymptomatic, can be just followed expectantly. But it also talks about when are tumor markers reasonable to get. In a postmenopausal woman, even a simple cyst, we're going to get tumor markers. But in a premenopausal woman, you're right, you wouldn't get tumor markers for a simple cyst. You just normally wouldn't. You would get it for a complex cyst, especially if it had any of the signs that are worrisome for malignancy. What about when would you refer an adnexal mass to a GYN oncologist?
If I had any concerns for malignancy, or I thought that the case was going to be more difficult in that technically, where it was, where I would want to make sure that I had additional skilled hands.
Yeah, and so that's another thing that they may ask you, when would you refer to the GYN oncology? And again, if you had elevated tumor markers or there was any findings by imaging that was very suspicious for malignancy, the patients will always be in better hands. If they have ovarian cancer, they are going to have better outcomes, etc., by having the initial and definitive surgery basically being done by the GYN oncologist. What else was I going to say? Something in relation. Oh, I know what else. Those, how there's the Roma and the OVA one, there's those different
Yes.
markers that you can assess degree of malignancy. Just remember, those are only indicated if you have an adnexal mass that you're going to do surgery on anyway. So it's a mass that you say, this mass needs surgery. Should I do it or should I refer to GYN oncology? That's what those, they're kind of, I don't mean to say just analytes, but they're kind of like algorithms of looking at different things to assess the likelihood of malignancy. And that's what those are for. It's not to say, should I do surgery or not? These are ones that you are for sure going to do surgery on.
Okay.
Good. All right.
Great.
Well, great. All right. Any questions?
No, thank you so much.
All right. Thanks. I'm going to see if anybody else has any last minute questions or comments before we just go ahead and then close out for the night. Oops, let's see here. Looks like Ebony might have a question or a comment. Hey, Linda, did you have a question or were you volunteering? Linda?
All right,
Hey,
volunteer.
Linda.
Yeah.
Huh?
Volunteering.
You were,
So yeah.
oh, okay. Well, we'll get you next time then. Thank you so much for volunteering. All right. Zishan, do you have a question? You're muted on your end.
Can you hear me?
Yeah, I can hear you now.
How do we, do you guys have access to our case list already, or how do I turn that in so I can be called on for cases? How does that work exactly?
Okay, so what you need is you would contact Beth at ExamPro, and then you submit the case, your case list to her, and then she posts it on this, she posts it on a server so that we can access it and pull it up.
Okay, perfect.
All right, thanks so much, but good question. All right, let me see if there's any other questions. All right, great. All right, guys, I think I've got structured cases with you somewhere toward the end of September. All right, good luck studying.